Hey guys, welcome back. I am still here with Dr. Bradley. We're going to do part 2 of the Type 2 diabetes series that we're doing. And in the last series, or in the last video, we talked a little bit about the newer oral and the newer injectables for type 2 diabetes. And we want to continue that on in this video. So if you're interested, stay tuned. Hey guys, welcome back. We are discussing the newer medications that we're using for type 2 diabetes. And Dr. Bradley was going into the DPP4s and the SGL2 inhibitors, and just telling us a little bit about that and when you would use them. So Dr. Bradley, what were you saying?
Okay, so the SGLT2 inhibitors are typically used in conjunction with other agents and also in patients who are diet controlled and have an exercise regimen. And these agents typically help the patient feel full faster, so they hopefully don't eat as much.
Also, what happens with these newer medications, what we're finding, and what I want to say to you, just because you guys know that I do a lot of studies on obesity, and these newer medications are actually helping people with weight loss.
Weight loss, that is correct.
Some people are using them just for weight loss, right?
That is correct.
In smaller doses.
In smaller doses.
Mm-hmm. And with the, I do want to say with the sulfonylureas, they cause you to gain weight. With the TZDs, they cause weight gain.
That is true.
Metformin does not cause weight gain. And insulin causes weight gain as well. So these newer medications, people are loving them. The only problem that I am seeing is the fact that some of them are injectables and people don't like that. So tell us a little bit more about the new oral medications, like the, what is that, Jemecia, the Jardins?
Okay. The DPP4 inhibitors.
Mm-hmm.
So the sitagliptin, linagliptin, and saxagliptin. Those agents are typically also used in conjunction. Low risk of hypoglycemia.
Dr. Bradley, we will only use those types of medications if we see that our patient is very close to their goal.
That is correct.
Their hemoglobin A1C goal.
Yes.
Right. We will use those to kind of get them right at where we need them to be.
That's right.
And keep them right there.
That's correct.
Okay,
Right.
That makes sense. Now, what I did want to find out is, I want to back up a little bit to metformin, and you talked about metformin.
Okay.
Before we go into that, you guys, I do want to say that even though Dr. Bradley is a pharmacist, and we are going to use pharmacologic medications or medications to treat type 2 diabetes, the first line treatment is weight control.
That's right.
And diet, and trying to incorporate some type of exercise. The only time you want to reach for a medication is if you find that your patient is way off. I mean, they are just out of control, it's unstable, and their hemoglobin A1C is above, is it 7.5 or above 7?
Actually, they're saying now 6.5, I think.
So you guys hear that? So if your patient's hemoglobin A1C is above 6.5, then we are reaching for those medications. But if the patient can bring it down through diet and exercise, then we won't have to do all of this. So I wanted to ask you about metformin. When would you not use metformin?
So if the patient has a cardiovascular disorder or high creatinine, then you may not go for metformin.
Okay.
You may not.
And would it be appropriate to go for one of the newer meds?
One of the newer meds or the sulfonylurea.
Oh, the sulfonylurea. Okay. All right. So that sounds wonderful. What tips or what else would you like to give to the nurse practitioner student or the new nurse practitioner prescriber when looking at all of these medications and what we should be, using or trying to use? I feel like industry is pushing a lot of these medications when metformin is working fine.
Right.
Metformin is really doing its job. Why do you feel like they're pushing all these newer medications?
Well, because they have to pay for the company. And you're absolutely right. Typically, that's what happens when the sales rep comes through the office, or it's the commercials you see on TV. That's the first thing that pops in mind. Oh, I can just use this particular medication, but you haven't tried things that we know are tried and true. And just always remember that each patient's treatment plan is going to be individualized. The patients should also have some buy-in to what their management plan will be. You always want to keep in mind their age, their weight, cost, other disease states, heart disease, kidney disease, liver disease.
Cost is big.
Cost is huge. That's right.
Cost is
so
big.
if you jump out there and start with one of the SGLT2s or the DPP4s, 9 times out of 10, the insurance company may not even pay for them unless they can see that you tried the Metformin, tried the glycyride,
Or one of the newer ones. or no, I'm sorry, one of the old school. Right. So what I think I hear you saying for the new nurse practitioner, the new prescriber, the nurse practitioner student, is to be sure that you look at the whole patient.
That's correct.
Their age, are they trying to lose weight? Have they been overweight for a long time? Because when you have a lot of insulin resistance and stuff like that going on in a patient, you're going to have to try several different things. And
keep in mind, lifestyle management is going to be number one.
Mm-hmm.
Like Dr. Braxton said, diet change, physical activity, smoking cessation, limiting alcohol, and actually controlling their triglycerides and cholesterol. Typically, if you get those under control, the diabetes will come down as well.
Oh, wow. Okay. All right. Hey, you heard it from Dr. Bradley, the pharmacist. So one last question. I know I said one last question, but this one is the last question. I know that there are several things that contribute to type 2 diabetes.
Mm-hmm.
And with you being a pharmacist, there are some medications that can cause type 2 diabetes. And those medications I know are thiazides. Mm-hmm. I know that there are some psychotropic medications. Mm-hmm. And how do we reconcile that?
So what I typically say is education and lifestyle. Know your history, your family history, and that way you can control the risk that may typically lead into long-term diabetes.
That's huge. That was a mouthful. That was great. Thank you so much, Dr. Bradley, for being here with us today.
Welcome.
We appreciate you so much. She dropped a lot of nuggets. I appreciate it. And hey guys, if you like this video, please leave me some comments. If you have any questions for Dr. Bradley, I will forward them to her and hopefully she'll get back to us on that. Guys, thank you so much for watching. Take care, guys. Bye-bye.